The sternocleidomastoid has two heads, a sternal head here and a clavicular head here. Both heads merge together to attach to the mastoid process of the temporal bone and along the occipital bone. To engage this muscle, we ask the client to rotate to the left, and the sternal head immediately pops out visually. To better see and palpate the clavicular head, we ask her to lift her head and neck up into the air, and we can strum across it. Here, flat palpation is being performed. Instead of flat palpation, as the client engages, we can also do pincer palpation, first of the clavicular head and then of the sternal head. The sternocleidomastoid is a superficial muscle and all of it can be palpated. To trace it, it begins at the sternum, runs up to the mastoid process of the temporal bone and along the superior nuchal line of the occiput, and then runs down to the clavicle, and very often there's a little gap between the two heads as seen there. To palpate the scalenes, it is best to first find the border between them and the sternocleidomastoid. We rotate the client's head to the opposite side and ask him to lift up, and the sternocleidomastoid pops. We find its lateral border, and from there we drop laterally off of that, and we're on the scalenes. To engage them, we ask the client to take short, quick breaths through the nose, and we can feel the contraction of the scalenes. We now palpate them within the posterior triangle of the neck by strumming perpendicularly across them. There are three scalene muscles all located within the posterior triangle. Here is the anterior scalene, which attaches from the first rib to the transverse processes of C3 through C6. Much of the anterior scalene is deep to the sternocleidomastoid. The largest, the middle scalene, is located here, and it attaches from the first rib to the transverse processes of C2 through C7. The posterior scalene, which is the smallest of the three, attaching from the second rib to the transverse processes of C5 through C7, is very challenging to palpate. To now palpate the transverse process attachments of the scalenes where they're deep to the sternocleidomastoid, we need to slacken the sternocleidomastoid by doing same-side lateral flexion. We can now push in under the sternocleidomastoid by asking the client to take short, quick breaths through the nose to engage the scalenes, and we can now palpate their transverse process attachments. The scalenes are superficial within the posterior triangle of the neck. The posterior triangle is bordered by the sternocleidomastoid, upper trapezius, and the clavicle. And here are the scalenes in the posterior triangle. To palpate the longus colli, we first find the sternal head of the sternocleidomastoid. To do this, we have the client rotate her neck to the opposite side and lift up, and the sternocleidomastoid pops. We drop immediately medial to the medial border of the sternocleidomastoid, and we first check for the pulse of the carotid artery. If it's felt, we either move off it or move it slightly out of our way, and then we press down toward the spine, feeling for the longus colli. If we feel we're on the longus colli, we ask the client to lift her head and neck into flexion, which will engage the longus colli, and we can strum perpendicularly across it. We then continue to explore and palpate the longus colli inferiorly and superiorly as she contracts and relaxes the muscle. The longus colli attaches inferiorly as low as the body of T3 and travels superiorly to attach to transverse processes and bodies as high as C1, the atlas. Because of the presence of the mandible, accessing the longus colli up to the atlas is extremely difficult. The hyoid group is a group of 8 muscles located in the anterior neck, 4 infrahyoids and 4 suprahyoids. To palpate these muscles, we first locate the hyoid bone, which is the first hard, palpable structure inferior to the mandible. We begin palpating this group by palpating the infrahyoids below the hyoid bone. We give resistance to depression of the mandible, and we palpate just lateral to the midline, strumming perpendicularly across them. We work our way palpating from inferiorly to superiorly. Above the hyoid bone, we are now on the suprahyoid muscles. Here, just inferior to the mandible, we are palpating the mylohyoid, and deep to that, the geniohyoid. If we palpate lateral from there, we are now palpating the stylohyoid and the digastric. As with the infrahyoids, we engage the suprahyoids by resisting depression of the mandible, and we strum perpendicularly across the bellies. The upper trapezius is superficial in the midline of the posterior neck. It attaches inferiorly or distally to the lateral clavicle and the acromion process of the scapula. From there, it runs superiorly to attach to the spinous process of C7, the entire nuchal ligament of the neck, and the external occipital protuberance and medial 1/3 of the superior nuchal line of the occiput. When the upper trapezius is relaxed, we can often find its superior border by pinching it away from the adjacent musculature as we see here. To engage the upper trapezius in the seated position, we contralaterally rotate the client's head and neck and then ask the client to extend back against our resistance, and we strum perpendicularly across it. We continue palpating the entirety of the upper trapezius as the client alternately contracts and relaxes the muscle. The splenius capitis attaches to the head and then runs inferiorly and medially. Its superior attachment is onto the mastoid process of the temporal bone and the superior nuchal line of the occipital bone, and it then runs inferiorly to attach to the nuchal ligament at the level of C3 and the spinous processes from C7 all the way down to T3. The splenius capitis is superficial in the upper posterior triangle of the neck between the sternocleidomastoid and the trapezius. We find the sternocleidomastoid with opposite side rotation and lateral flexion to the same side, and then resist further lateral flexion, and the sternocleidomastoid pops. We then drop posteriorly off it onto the splenius capitis here, between the sternocleidomastoid and the upper trapezius. Now, with the client's head rotated to the same side, he pushes back into extension, and the splenius capitis engages, and we can strum perpendicularly across it. We follow it inferiorly as far as possible. It will go deep to the upper trapezius as it approaches its inferior attachments, but can still be palpated. To access the inferior attachment of the splenius capitis deep to the trapezius, we first locate the border of the upper trapezius when it's relaxed. After doing this, we reach in slowly with gentle but firm pressure toward the spinous process attachments of the splenius capitis, strumming perpendicularly across it. The semispinalis capitis, the largest muscle in the neck, is deep to the upper trapezius. To better palpate the semispinalis capitis, the upper trapezius needs to be inhibited and relaxed. We can do this in two ways. One way is to have the client place his hand in the small of the back. This requires extension of the arm at the shoulder joint. which requires downward rotation of the scapula at the scapulocostal joint, which then reciprocally inhibits the upper trapezius because it is an upward rotator of the scapula. The second way is to ipsilaterally rotate the client's head and neck to the right side here because we are palpating the right semispinalis capitis. And because the upper trapezius is a contralateral rotator to the left, ipsilateral rotation to the right will reciprocally inhibit and relax it. Here we see the hand in the small of the back. Now we are ipsilaterally rotating the client's head and neck to the right. We palpate in the posterior neck, finding the spinous processes, and then we palpate just lateral to them. We are now on the upper trapezius, and deep to that, the semispinalis capitis. We now ask the client to press his head and neck back against the table, giving resistance to extension of the head and neck at the spinal joints, and we feel for the semispinalis capitis to engage. We strum perpendicularly across it, and we follow the course of the semispinalis capitis from attachment to attachment as the client contracts the muscle by pressing against the table and then relaxes the muscle. The suboccipital group is composed of 4 deep muscles in the upper neck that attach between C2, C1, and the head. They are the rectus capitis posterior major from the spinous process of C2 to the inferior nuchal line of the occiput, and the rectus capitis posterior minor from the posterior tubercle of C1 to the inferior nuchal line of the occiput. These 2 muscles are parallel to each other. Then we have the obliquus capitis inferior from the spinous process of C2 to the transverse process of C1, and we have the obliquus capitis superior from the transverse process of C1 to the occiput between the inferior and superior nuchal lines. Let's look from the posterior view to better see the bony attachments of these muscles. There is the spinous process of C2, and rectus capitis posterior major goes from there to the inferior nuchal line of the occiput, and we can strum perpendicularly across it to palpate this muscle. We usually do this when the muscle is relaxed. Then we go from the spinous process of C2, and we drop just off it superiorly for the posterior tubercle of C1, and the rectus capitis posterior minor attaches from there, running parallel to the major to attach on the inferior nuchal line of the occiput, and we then strum perpendicularly across this muscle also when it is relaxed. To palpate the obliquus capitis inferior, we start on the spinous process of C2 again, and we trace a line to the transverse process of C1, and then we strum perpendicular across that line, palpating from the spinous process of C2 to the transverse process of C1.